Hello, everyone. Welcome to the first of a series of webinars being hosted by the Rare Diseases Clinical Research Network. And one of the goals of this series is to serve as a platform where there will be an amalgamation of ideas towards improving the diversity, equity, inclusion, and accessibility of the people we serve. Before I introduce our speaker today, permit me to go through a few housekeeping items. Again, I just on the slide, this is a diversity committee that is hosting the series. This is the first of many series to come. And the presenters in the forthcoming series will include leaders in patient advocacy, clinical care, academia, and any other resource that we find will impact the improvement of diversity, equity, inclusion in the work we do. We hope you will look forward to the next webinars as we send out the information over time, and you will join us if you have any ideas also of topics you would like us to talk about. We'll encourage that. Please spread the word. Yes. We will encourage you to keep your devices muted, and we appreciate that. During the presentation, there will be a Q&A session at the end of the talk, and you can use the raise hand feature during the presentation. We will find a way to get each one to have their questions answered. And there will also be the chat room be monitored. So if you have any question in the chat room, we'll be able to also respond to that. There will be a post-webinar survey that we encourage all of you to participate in because we want to use that to improve the series of seminars that will come later. And this recording will be available to anyone who is not able to stay at the end of this for their review later. Having said that, I will let my co-chair, Denise Gas, talk about the next event coming.
Hi, thanks, Della. We've got an upcoming event. It's on your screen right now. If you check the chat in a second, there will be a link to register. It's a little bit different. Our webinar series is going to be some case studies from rock stars like Tonya today. This upcoming event, please make note, it is a workshop series. We're going to be sharing some exciting and inspiring stories, but we're also going to be breaking up into small groups and outlining a format for you to identify where you can start making positive change in your organization and a framework for measuring your continual advancement and improvement. So make a note of it. We'd love to have you there. It's going to be a working session from 12 to 2 p.m. Eastern time on September 28th. Back to you, Della.
Thank you, Denise. Today we have Tonya Winders. She has a resume that very, very impressive as I went through. And we are very fortunate to have her here today with us. She's the CEO and president of Allergy and Asthma Network. Tonya has over 20 years of experience in leadership, working tirelessly through grassroots education and advocacy initiatives with her program. She actually is very invested in ensuring that all patients, most importantly, those who are marginalized, receive great access to effective diagnostic tools and treatments. Most recently, she led a group in developing a program that partnered with churches and community-based organizations to address COVID-19 vaccine hesitancy in underserved populations. She's a fierce fighter and a patient advocate who has authored more than 20 peer-reviewed publications and speaks globally to ensure patients have their voices heard. Today, she will talk to us about some of the determinants of healthcare disparity that are not so obvious. And I'm sure she will share with us some of the great work that has been done under her leadership with her group. Without that, I will say, Tonya, welcome, and please take over.
Again, good afternoon to everyone. Thank you all for the opportunity to be here and to share a little bit about this topic that I am very passionate about, which is redlining of healthcare. While I'm not in a rare disease space, I am in more chronic care disease space of asthma and COPD, and that's the basis of my talk today. I think so much of this still applies across the board, whether we're talking about chronic disease and or rare disease. And so again, I like to start a little here with just who I am and my why. We all have different whys behind the what we do and why we do it. And for me, this particular topic of diversity, equity, and inclusion has been one that has been a passion since I was actually a very young girl. I grew up in Louisiana, and I was in a part of the school that unfortunately was not very diverse. And we had some history of redlining of communities in my community. And very young, I began to question this, and I began to ask my parents why there weren't individuals that looked different than us, and why there weren't other friends that were of different races. And oftentimes I was met with a lot of harsh responses about, or just unsatisfactory responses about those things. And so it definitely became a real priority and challenge for me at a very early age of just questioning these things and really trying to understand more about this. And so when I became the CEO of Allergy and Asthma Network and had the opportunity to really look at our mission work of outreach, education, advocacy, and research, I began to always think through, where is the unmet need? And time again, the same answer came about, that the unmet need was in communities that were unfortunately poor socioeconomic and did not have the education privilege or the economic privilege or some of the systemic justices that I had had as a child. And so it really has become the very core of the work that we've done at Allergy and Asthma Network, and I'll talk more about that as we go along. So I have 3 key objectives for today. The first is to understand kind of what the current asthma health disparities landscape looks like and some of those underlying structural drivers, and then the system level interventions that we really need to help close the disparity gaps. And then secondly, we'll look at how to utilize an appropriate lens when really looking and talking about health disparities, because I think this is changing and evolving. And what we've recently seen is that even some very, seemingly harmless decisions around race-based spirometry have had backlash and really and truly are not scientifically based. And so I think that this adds to that mistrust and distrust that the community has often had. And then finally, we'll talk about how to improve the consideration of different contributors to health disparities in clinical practice. So first, the disparities in asthma cannot be denied. When we look across the US, this is the 2019 data, you can see that asthma does impact about 8% of adults and 7% of children, about 9% females and 6.6% of males. But then when we look at this by race and ethnicity, the numbers begin to really separate. And you can see that in the Caucasian white population, it's 7.6%, while in the Black community, 11.2%, and in the Hispanic community, 6.8%. And so again, that current asthma prevalence by race and ethnicity over the course of the last really 20 years has not, we've not seen those numbers change. Even though we've had specific efforts around addressing the unmet need, around programming in those communities that are of color and have the most need, unfortunately, we've just not had the impact that we would like to see. So still work to do. Now, when we look at specifically the asthma data here, you can see when we look at emergency department utilization and urgent care visits, when we look at death rates, again, disproportionate. And so the access to emergency room and urgent care visits, higher among the Black community, as well as the multi-race community and Hispanic community, compared to that of the Caucasian community. And then the mortality rates actually are significantly higher, with Blacks having up to a 7-time greater likelihood of death due to asthma than whites, and Hispanics, especially Puerto Ricans, as well, a multiple of over 6 times. And so many of you may have seen this type of slide before that really helps to elucidate the difference between inequality versus equity and equality versus justice. And I think that this is important because the words we use around health disparities really can harm or help if we're talking about, leveling the playing field and addressing some of the unequal access to opportunities. So inequality is defined as unequal access to opportunities. Equity is custom tools that really identify and address those inequalities. And then equality, really thinking about how are things evenly distributed, the tools and assistance. And justice is even deeper. It's how do we fix the system to offer equal access for both tools and opportunities. So justice is that highest level of addressing the inequalities that currently exist within our culture. And this slide really points out where some of those intersections of equitable access lie. And so we know that, again, part of this is community-based. Different neighborhoods, different zip codes have access to different services, even one zip code apart in certain cities. We've been doing projects in Atlanta and Chicago and, throughout the US and major metropolitan areas. You can literally go from one zip code to the next or one neighborhood to the next and see very different pictures of access and healthcare needs. And then healthcare infrastructure, how is the healthcare system, actually structured in different communities, neighborhoods, and zip codes, as well as that social and economic opportunity that we know, again, unfortunately is not equal across the playing field. And then there are environmental factors and certainly other factors. And so here on the bottom up, it's really that individual level, right? So it's the ability to perceive, the ability to seek out those care needs, the ability to reach those care providers, the ability to pay, and the ability to engage. On the top down, it's really the provider's responsibility. It is that approachability of the provider, the acceptability of the provider, the availability and the accommodations that are made by the provider, the affordability of the services, and then the appropriateness of the services. So I think that this is the, if you will, the push-pull that is currently broken in so many ways, and that is contributing to what I deem as the redlining of healthcare in our country. And so when we start to talk about redlining of healthcare, it's good to take the macro level and then bring it down to the micro level. Certainly there is the history, the unfortunate history of our country of social disadvantage and oppression of certain individuals and populations, communities of color specifically, but also poor socioeconomic status. There are environmental strains within that community as well. Things like pollution, additional stress, which makes all conditions and diseases worse, and then additional environmental exposures that may be driving some of these outcomes. Then there's the discussion of epigenetics, which is where the environment and the genetics intersect. And again, we know that even at that micro level, when we talk about asthma disparities, there is some conversation around varying pathophysiology and certainly different outcomes for different populations. So you hear the term social determinants of health quite often, but how is that really defined? What are we talking about? And are we using that terminology consistently? The World Health Organization defines social determinants of health as the conditions in which people are born, grow, live, work, and age. And this is influenced by a myriad of different factors, including economic, political, and social factors. And all of these are linked to health inequities. So we certainly have to take a step back and think about what are the avoidable inequalities that in healthcare between different groups that we can address. Things like poverty, housing insecurity, food insecurity, immigration status, early childhood adversity. All of these are different social determinants of health. And health equity means that everyone has a fair and just opportunity to be as healthy as possible. And this is a quote that I love from the Robert Wood Johnson Foundation, which really reinforces why we do what we do when it comes to this work in diversity, equity, and inclusion in health. Now, the CDC has been very vocal and forthcoming about some of these topics. And I think that this is a paper, a policy statement that was actually put out by the American Academy of Pediatrics and the CDC, two different policies here that say racism is a serious public health threat that actually directly affects the well-being of millions of Americans and actually impacts our entire nation. We can't just think about it as the directly impacted population because it's not a zero-sum game. It's not as if, if one community is losing, that we as a different community may be winning. When it comes to health, it's we really are on the same team, and we should be looking at this not from a zero-sum mindset of win or lose, but from a collective mindset of what is really best for the overall population. And so this statement here, the American Academy of Pediatrics, raises the social determinant of health that is absolutely a driver in health inequities. And that again goes to those conditions in which people are born, grow, live, work, and age. And so what is racism? Again, it's a term that we hear about, we talk about, that by definition, it's actually a system of power and oppression that structures opportunities and assigns value based unfairly on disadvantaged people. Racial oppression is the most common of that. And so while unfairly advantaging others, those that are racially privileged, it really saps the strength of the whole society. And this is what I was saying before about it's not a zero sum. It's not like some are winning, some are losing. When racism is alive and well, unfortunately, it hurts the society as a whole. So what are those internalized, interpersonal, institutional, and structural differences and opportunities that have led to this? And again, we all know about our history of Native Americans and the land that was taken from those Native Americans. This is a story of a Yoruba American woman who was really the last known survivor in the US of that transatlantic slave trade and the ship Clotilda. And she was captured and then brought to Mobile, Alabama at the age of 2 and sold into slavery and was held in slavery for much of her life. And so, when we think about that versus her great-grandson today, here you see here is a successful, free African-American male. It's a completely different structure. And yet we have a history of 246 years of American slavery in the US. And it wasn't until the period of segregation between Reconstruction and the Civil Rights era that we began to address some of these systematic existence of power and oppression. And so I think that, again, when you look at it in this state, hopefully it helps you to see why we're on the journey. And I think we've made some progress, but we still have such additional progress much further to go. So what are the different levels of racism? And again, I think that we can think about this on 2 different levels. First of all, remember, this is racial prejudice that's backed by power and resources, and that racial inequity is a problem, really a bad policy that has manifested itself in people, but it's not that people. And it really is that policy that we're working to change. So there's 2 levels. First, institutional racism, which occurs within and between institutions and really manifests that discriminatory treatment, practice, and policy. And that results in those inequities that we talked about before. And then secondly, structural racism. And so this really involves that interconnectedness of institutions whose linkages are historically rooted and culturally reinforced. And it refers to kind of the total way in which society fosters that racial discrimination. And through mutually reinforcing those inequitable systems, it reinforces discriminatory beliefs, values, and the distribution of really important resources, which that's what we're going to talk about here, is how this redlining of healthcare has actually taken place to affect the risk of adverse health outcomes. So let's go back to the Great Depression. Definitely when we think about the federal government and the way that the Great Depression was happening and some institutional racism that occurred, it came out of an effort called the Homeowners Loan Corporation Act. And it's important to know our history because we have to know where we've been to know where we're going and how to keep addressing these policy issues and make the world a more equitable place. But this act actually was created for standardizing criteria and for determining that credit worthiness of different neighborhoods in American urban centers. And it was that credit worthiness that basically depended on, could you get a loan, and therefore could you get a home? And so white neighborhoods were designated as the best area for investment, while non-white areas were disproportionately designated as hazardous or redlined as risky for investment. And it was these kinds of residential security maps that you can see for Los Angeles, for New Orleans, for Oakland, Charlotte, North Carolina, all across the country. There were these types of maps which actually rated Black neighborhoods as the lowest grade, and therefore they were shaded red. And that's where the term redlining came from. And again, you can look throughout pretty much every major city in the country, and this is what happened during the Homeowners Loan Corporation Act. And so it's this type of institutional racism that, again, creates those inequitable opportunities for home ownership and really negatively impacted those marginalized racial groups that sustained those racial outcomes that we see today. Now, what happens when we then take a look at those red line maps versus asthma, ER, urgent care, and hospitalization? Now, in Kansas City, Missouri, you've got the red line map on the right. You've also got a heat map for how asthma ER visits are panned out on the left between 2016 and 2018. And what you see is those red neighborhoods, the red line neighborhoods, had 4 times the annual visits of urgent care, ER, and hospitalization. And so again, you look at how this policy on a macro level has impacted individual families on a micro level, and certainly population health regarding asthma at community level. And what we've seen is that across the board, again, not just in Kansas City, but across the board, these associations between historical residential redlining and current age-adjusted rates of emergency departments across 8 cities in California in this one. So we took a look at the micro of Kansas City just a moment ago. Now we're looking at 8 major cities in California. Again, when you look at that redlining residential adjusted rates, we always see how the rise in emergency department utilization and urgent care utilization mirrors those redlined communities. And then when we take a look again, even at a more universal standpoint of the American population, you can see how the minority percentages of the population are dispersed throughout especially throughout the southern part of the United States, and how Black and African American individuals were actually 40% more likely than non-Black and non-African American individuals to currently live in those areas where there's worse pollution, where there's worse climate change impact, where there's more extreme temperatures, and all of those things negatively impact health. And so again, we have to think about how these redlining policies have impacted clean air, clean water, access to food, access to housing, access to education. It really is a domino effect that has occurred throughout our nation's history, unfortunately. Now, what about stress? We know that, again, in poor socioeconomic communities, that the stress levels are higher. And several studies have evaluated that relationship and the toxic ability of chronic stress on asthma. So we know that it's equal to or greater than 4 asthma exacerbations leads to 2 times or more likelihood of asthma in those allergic conditions. So living in that, those chronic stress situations, those adverse childhood experience situations, actually leads to more ongoing stress and ultimately more comorbidities like obesity, learning and behavioral problems, depression, anxiety, and so much more. And so what happens in the first 10 years of a child's life really does have significant defining activity in how they think about life, how they interact with the health system, and certainly how they view their own health, as well as their empowerment to really take control of their own health. And so this is what this slide is really speaking to. Now, when we look at, again, racism as a factor on things like housing insecurity, food insecurity, expanded childhood stressors, conventional childhood stressors, racism if you experience racism in the last year, or if you've experienced racism over your lifetime, we see the stress impact of race across the board. And again, I know I'm not saying anything you haven't heard and you don't know in the work that you're doing for your disease state, but I think it's so powerful when we start to look at, again, all of these systemic issues are adding to that stress and negatively impacting health. So again, by 1947, half of the veterans that were coming out of the military, they actually made up half of the national college enrollments. So half of all college enrollments were veterans in 1947 as a result of the GI Bill. And veterans who attended college also tended to have more children, tended to have grandchildren. They were creating this pipeline, if you will, of white collar careers coming out of that. And so the GI Bill benefits were not equally distributed across all races. And it was that negative interest compounding of each generation. So if you again, served in the military in the 40s during the First World War, then you would actually get the benefit of paid college. That was not equally distributed among all races. And so again, this is how we have created generations of inequities. It didn't just stop with the activity of desegregation. There have continued to be even education policies, economic policies that have reinforced the gaps. So what about in the most recent days of COVID-19? It's okay to talk about perhaps the 1800s, the mid 1900s, but what about now in 2020, 2021, 22? This actually is a study that looks at the relationship between structural racism and COVID-19 across 10 metropolitan cities in the US. And this is the data that got our attention to actually develop a program to specifically address the gaps that we were seeing in COVID-19. And so again, what you can see is that unfortunately, the racially disadvantaged were at much higher rates for death from COVID-19, as well as for hospitalization from COVID-19. We also know that early in the pandemic, there was less access to vaccine, there was less access to testing in those communities, and there were many, many different factors that were, again, continuing to reinforce and shine the light on the disparities that have existed in our country for quite some time. So in 2019 and 2020, one of the factors here is around workforce. The healthcare workforce actually, unfortunately, is also ethnically distributed in a way that does not encourage the addressing of disparities and inequities. We know that through many, many surveys that patients would like to see a doctor or would trust a doctor who looks like them. And yet when you look at the difference of of Black and Hispanic physicians, the numbers tell the story. And this here, you can see the racial and ethnic distribution of the US population versus the current physician population. And so you see in the non-Hispanic white, it's pretty similar, 60 to 56. But when we look at Hispanic, great difference, 19 to 6. When we look at Black or African American, 13 versus 5. And so again, a definite red flag, if you will, of workforce development needs to make sure that we have education opportunities for Black and Hispanic providers to go to med school and to, again, begin to offer services back to the communities in which they grew up. Now, many of you have an interest in underrepresentation in clinical trials. And so I added in this slide because I think it speaks really to the fact that right now, clinical trials are truly not representative of the full diversity of a patient community. And so here at the top, you've got the United States population, which has 72% that claim to be Caucasian or other, 12% that African American, and 16% identify as Hispanic. But when we look at clinical trial participation, it's over 94% Caucasian, with only 1% being Hispanic and 5% African American. So this again points out to the fact that we have to do a better job of including members of racial or ethnic minority groups, because right now it just is not what it needs to be. And in fact, NIH has recently set a standard that has recognized the fact that less than 5% of all NIH funded published studies actually had that inclusion of racial or ethnic minorities in making sure that was a concerted effort. And so this is an issue that we've had in our own community, going back to NIH and saying, we have to do better. We have to set, if you will, quotas or standards, expectations of researchers to be truly recruiting and engaging individuals of all race and ethnic backgrounds in order to represent the full community in the clinical trials. So this is in the food allergy space, because if you thought that it was just in lung disease, it's not. In the food allergy immunotherapy trials, again, you can see that the vast majority, over 90% were, actually, sorry, I think that's 81%. My eyes are not working too well. That's small print. 81% were white or Caucasian, while it was 1% Hispanic. No, that's 91. Sorry, it was very small on my screen. And then 6.5% that were multi-race, less than 1% Native American, 7% Asian, and about 2.5 to 3% Black or African American. So again, not equal to that of the general population. And so we have to do a much better job across all therapeutic areas, across all disease areas, of ensuring that our clinical trials are more representative of that full community. Now, this is the topic I was talking about before, and it's not a new topic, because even back to 1783, there were some documents and claims that Black and white lungs, Black people's lungs, white people's lungs were different. The first actually was mentioned by former President Thomas Jefferson in a speech on the notes on the state of Virginia. And yet it was really reinforced, unfortunately, to justify substandard slave living conditions and to point out the inferiorities of Black people. And then there have been, even in the 1800s, in the mid 1900s, additional thoughts around differences of the lung. This, in the lower left-hand side, it says the smaller lung capacity of the colored race is in itself proof of inferior physical organism. And that was Gould in 1969. And he was really the basis of this race-based spirometry correction that has resurfaced even in the last 2 years. And it's so unfortunate, because this is reinforcing very disturbing historical trends that are not evidence-based and that are fundamentally flawed. And so again, I have talked with experts all over the world about this. And the truth is, there should be no race-based face adjusted results for spirometry. And we are working hard to right that wrong in the literature. And so again, I've talked about a myriad of ways, and it may seem a little bit discouraging or disappointing about how far we have yet to go when it comes to creating that more equitable environment, to really addressing some of these systemic injustices and moving forward to justice. But I want to leave you with some encouraging words about, ways that I think that we can do that. One is by really thinking through those social determinants of health, going back to how do we train healthcare providers to openly discuss, and how do we empower patients and people to openly discuss things like their education level, like their socioeconomic level, like the challenges of living with a disease specific to their cultural beliefs. And these are, again, different ways that we are going about having a more community-oriented approach and connecting people to the resources that they need to be more empowered, to have that ability to know their rights and to advocate for their rights. We have to help people to understand their healthcare. We've been advocating for more universal healthcare. We believe that health should be a right for all people, not for some. And so I think that, it is about that policy change. It's about driving research change, certainly about healthcare coverage and insurance navigation, but ultimately advocating for what is the best care and the best treatment option for you individual. And we have to continue to address the ingrained legacy of inequity. How do we, for example, address that systemic racism? On an individual level, it is making sure that we've got a more diverse workforce. It's ensuring that the research workforce is also diverse, because we know that even participation in clinical trials is often determined by the person connecting on that one-on-one basis. And as you talk about the trial, encourage someone to participate in the trial, give them that opportunity. Do they feel trusted? We had a PCORI engagement award for African Americans with asthma and for Hispanics living with asthma, where we had this ongoing discussion about the myths and misperceptions, the mistrust, that it was so deeply ingrained through the sins of the past. And it was so powerful when we heard from patients who said, number one, we just want acknowledgement. We want people to say, yes, this really happened. Yes, we are sorry that this really happened, and that we are committed to doing better as we move forward. We also have to address some of the systems, the medical system, the healthcare system, the education system, the economic system. All of those are systems that have to have great reform in order to truly achieve that inclusive excellence that we all strive for and desire. So the bottom line as we come up on the end of the presentation and our time together is, what can I do? Because sometimes this feels, I don't know about for you, but for me, it feels very overwhelming. Like, we've got hundreds and thousands of years of ingrained behaviors that seem almost impossible to change. And so I wanted to leave you with a few things that I think each of us can do to help ensure that this zero-sum mindset is altered. First of all, look in the mirror and start with yourself. What is your why? Why are you in this space? Why have you stayed in this space? Why are you passionate about diversity, equity, inclusion in healthcare? And realize no one has to lose for all of us to win. It is not a zero-sum game. It is absolutely not. There is plenty of healthcare, will and need for us to go around if we just allocate the resources more effectively. Secondly, we have to be willing to step up as leaders in healthcare and advocate for policy change. Not just healthcare access, things like digital health and telehealth, things like workforce development, things like universal healthcare coverage. Those are all important and absolutely critical to righting the wrongs of the past and getting us on a more level playing field. But it goes beyond that. It includes things like voting for individuals and advancing policy change for education, for fair living wages, for really removing this debt for diploma mindset that we have today, which puts poor socioeconomic communities at even greater disadvantage. Because why would you come out or go to college and invest in that when you're going to have hundreds of thousands of dollars of debt left over after the fact and still be making a less than fair living wage? The economic policy, we have to ensure that our tax rates are fair. We have to ensure that our housing and lending practices are fair, and that the redlining that occurred, as we talked about before, never ever happens again. That we begin to really create those justices that will ensure all people have the opportunity, if they so desire, to own a home, and again, to provide that, housing security, food security, education, all of those things for their children and grandchildren and generations to come. We also have to address some of our criminal justice policies. We've had more mass incarceration policies that really were aimed at certain communities of color, and we have to stop this, if you will, thought of overgeneralization around gang violence and drug use. And, when I think about this particular space, I think about the drug, the war on drugs from the 80s and 90s, and the way that this put so many of our African-American brothers and sisters in prison for very long terms. And yet, contrast to the opioid addiction crisis that has predominantly been in the Caucasian community over the last 10 years. We don't see the same sort of mass incarceration of the opioid crisis that we did in the war on drugs back in the 80s. And so I think that, again, we have to right some of those policy wrongs. On the environmental level, it's things like clean air and clean water, as I said before. And then even in our voting policy, it's things like we've talked about, from registration and suppression of voters. It's things like our electoral college system and the way it was designed that may need to be relooked at. And again, this is a very complicated topic, but I just wanted to get your brain thinking about ways that, unfortunately, our history has reinforced the gaps in these communities. And ultimately, I think that we have to stay focused in healthcare on achieving the quadruple aim for all, not for some, for all. How do we get better outcomes? How do we continue to lower cost, ensure a better patient experience and a better provider experience? Because that's what it's going to take for us to really close the gaps that have existed for so long in so many chronic disease areas and in rare disease areas. And the truth of the matter, the bottom line for me, is no one should be deprived of the basic necessities of life in the wealthiest country in the world. When you know better, you should do better. And I go back to myself on that playground in elementary school and middle school and high school, when I was constantly challenging my friends, my parents, other loved ones. I know better now. We have to do better now, because people, unfortunately, are dying due to systemic injustices and to the lack of diversity, equity, and inclusion in healthcare. And so with that, I will take any questions, any comments, and certainly be happy to spend the balance of our time with addressing your concerns.
Thank you, Tonya, for this comprehensive presentation. There are a couple of questions in the chat from I'll read one. Let's see here. It says, has there been any hospitals that successfully removed the race-based parametric correction from their algorithms?
So I know that there have been specific programs, like in the community that I showed you of Kansas City, right? There's very specific programs. There's a very specific program in Memphis, Tennessee, that has been more effective at righting some of those wrongs and balancing the scales for those high-risk populations. But I can't say that I've seen one that's working perfectly across the board at this point. I think we still have a lot of room to go. And part of that is our healthcare system and our coverage, right? We have 5 major payers in the US. We have over 5,000 different health plans. And so what is your covered benefit versus my covered benefit versus anyone else's is quite different.
And the follow-up question is this a device problem, or do the hospitals need to force a change from their suppliers?
Yeah, I think the problem is even at a higher level, right? Because unfortunately in our fee-for-service system, the wrong behaviors are oftentimes incentivized, right? You've got to see someone every 5 to 7 minutes in order to, get those RVUs, the payment way that hospitals are reimbursed. And so it does not allow for appropriate time or value the right things like shared decision-making, like asking the right questions around that social determinants of health. None of that currently is part of the protocols or is consistently reimbursed.
Another question here. What are the NIH's recommendations to increase diversity within clinical research?
Yeah.
Anything about that?
Yeah, the NIH really is taking pretty strong steps forward and is actually requiring that every single clinical trial that comes through NIH, that's funded through NIH, has an initiative, a specific program and plan for representing underserved communities. And again, we're looking at the disease prevalence in those communities and making sure that the clinical trial recruitment is reflective of that. And so, for example, the numbers may be higher in a condition like sickle cell, whereas they are compared to, say, asthma or COPD.
Yes, that's true. In my, I do clinical research in sickle cell disease, and I realized in applying for some grants, there's now a request to indicate involvement of the different ethnic groups. So I think that's a positive side from NIH.
Yes.
I don't see any hands. Sheridan, any hands raised?
No hands, but Denise.
Okay. I have one question. We know that President Biden, he signed an executive order to improve the diversity, equity, inclusion in the workforce. I think last year. Is there a parallel input from the private sector to move this forward? I know this is, I think, must have from the federal workforce.
Yeah, I know I can only speak to my own space, right? So yes. Respiratory immunology. I've had these conversations at the highest levels with the largest companies about the need for them to really step up and to redirect much of their profits toward ensuring that we do have a more diverse workforce, and that workforce is valued, and again that they're not in so much debt when they come out of med school that they that it's impossible to go back to the communities and serve. And so I think that again there are programs and incentives to encourage individuals to go into healthcare, specifically in rural communities and poor socioeconomic communities, federally qualified health centers. But the need for private industry to start putting their wallets where their mouths are is long overdue. And I can tell you at Allergy Asthma Network, we received a large corporate social responsibility grant from Sanofi to do work in underserved communities during COVID, as I was saying before. And it was the first time we've had a DEI initiative around clinical trial participation, around addressing asthma disparities. We've had that in place for 20 plus years, but it took COVID shining the light on these disparities and inequities to get industry to open their wallets fully.
And one final question, we're almost there. It looks like this intricate network that ended up with redlining has a very powerful political undertone. Is there any initiative to inform our elected leaders, any political park or any powerful in the group that is coming together to try to educate them and more so maybe even force them to influence some of these changes? Because we know that most of these people, they need to be reached out to.
Right. Well, I think it starts with each of us, right? We have to, number one, educate them. We have to make them aware. We have to also hold them accountable, because oftentimes they say the right things at the right time in order to get elected. But then when it comes to voting in Congress for policy changes and for the rights to these wrongs, their votes don't align. And so it's at that point that I feel like, I know, and I again, grew up in Louisiana, have lived in Tennessee, as well as in Virginia, DC area. And we have to hold our elected officials accountable to not just saying the right things, but doing the right things when it comes to actually voting.
We're almost done, but a few questions just came up. If we could answer them briefly, quickly. The question is, in rare diseases, we see problems with accurate diagnosis numbers and getting access to care. Do you have any advice for how rare diseases can start and further up the funnel?
Yeah, and it's so hard because we're all doing a lot of work with very little resources, right? But it's how do we make sure that we are trying to get the most accurate information about our full community in order to share that. And so I think that what I would say is, for us, we have partnered with churches, we have partnered with social influencers in those communities to get the word out, to help. We've gone to community-based outreach efforts to do screenings. And so it's just take it. And again, I know it's really hard in a rare disease with limited resources, but it's finding those community partners and then leveraging them and leveraging the trust that they've already established in that community to get better engagement in data. And then I saw the question here about clinical trials.
Yes.
How do we build trust? So again, we had over 5,000 African Americans and Hispanics in our PCORI Engagement Awards living with asthma. Universally, they said, acknowledge the past. That is the first step to rebuilding trust. Acknowledge the past. Don't try to sweep it under the rug or act like it didn't happen. Tuskegee happened, right? And so acknowledge the sins of the past. Empathize, ask for forgiveness, even if you weren't the one who was actively involved. Ask for forgiveness on behalf of the scientific community. But then also address their real life myths and misperceptions, as well as their concerns. We have to design clinical trials that are easier for people to participate in. That's why, again, the decentralization of clinical trials during COVID has been so important, because no longer should someone have to take off of work an entire day to just participate in a clinical trial visit, right? No longer should they have to choose between putting a roof over their child's head or food on their table versus helping to advance the science. And so pay people fairly for their time, for their efforts, make sure that we can decentralize as much as possible, keep people in their jobs, in their homes, with their families, because at the end of the day, we all really want to be people, not patients.
Thank you so much. I think our time is up, and there's a link as to what happens when clinical trials don't adhere to the recommendations.
Yeah. So
please,
right now,
all of you, remember to complete, sorry about that, Tonya, complete the survey. We need that, please. Tonya, again.
No, I was just going to say thank you again for the opportunity to be here. It's been great. Sorry for the technical issues and any background noise. Had to go to a more public spot to make sure I was stayed connected. No. It's been a pleasure, and I really look forward to hearing the great work that you all continue to do in diversity, equity, and inclusion.
Likewise, we're happy to have you, and we know that our previous session had to be canceled, and we're glad that you could make it this time. Yes. Thank you.
Thank you all. Take care.